Hi friends, it's Dr. Russ. Today on our table we have Brie. Brie has had quite a few health issues coming up in the last few years. Ménière's disease, tethered cord syndrome, adrenal fatigue, pain, all sorts of things. So she's on the road to recovery and doing really well. She's got some great providers on her team and a really, I think, solid treatment plan. She had surgery for the tethered cord syndrome, which seems to have helped a lot. So she's here today. We're going to work on her head, neck, and shoulders, do some cranial work, relax the neck, open up the shoulders and the rib cage, and see if we can help the system relax, open up, help the breathing, help the neurological regulation, and just help Brie along on her road to recovery. So let's get started. So we're just getting started. I saw Brie first time many years ago, and I remember the first time you came in. It was probably 2011, and you couldn't move your head. Do you remember? No.
I don't remember.
Yeah. Okay. She came in torticollis of the neck, totally unable to move her head. And I remember you walked in and you looked very sad and scared. Okay. So initially, just sensing the general tone of the tissues and the kind of the general way that things are fitting together here in the upper body. Definitely feeling some constriction and compression in the lower cervical segments right through here. And the way that I sense that is with my right hand, I'm cupping her occiput and tractioning toward me. And by doing so attentively, I'm getting a sense not only of how much slack and pull and give there is through the upper spine, but also I can feel where is that restriction taking place? How far from my hand is it? And that's something that you can develop that skill over time. So yeah, sure enough, as I get my fingertip along the spinous processes of those lower cervical vertebrae, let's turn your head a little bit. So right along here is definitely a sense of approximation in there. And that's not necessarily correlating to a tethered cord syndrome. That's just how people's necks dysfunction. That's kind of a typical pattern, is the lower cervical segments get a little bit smushed together, for lack of a better term. So one approach, not mine, would be to just pull really hard on their head and open their cervical spine like a bendy straw. But I don't think that's very safe, and I don't think that it really provides a lasting change. Because the reason that the segments are doing this, and usually that reason is because the head has come forward in the posture. And the reason the head has come forward in the posture usually is because the sternum has sunk in and down. And so we have some videos on the channel here about breath work and postural change, and we talk a lot about lifting the sternum. So we're going to be working on that here as well today. But first, again, just kind of getting the tissues warmed up, getting the patient's body and nervous system accustomed to being manipulated and the touch and being moved around, and just getting a sense of anywhere else that she might be holding tension, anywhere else that might feel like it's an area of chronic strain, somewhere that the biomechanics just aren't working optimally. Okay, working up the right side now and feeling a lot of tension right in here. And is this the affected ear on the Ménière side? Okay. Mm-hmm. So again, I'm not one of those who's going to say that the biomechanical issues in her right sternocleidomastoid, especially the upper 3 inches of it, where you will find most of the dysfunction of this muscle right here, and these 3 upper cervical segments, occiput, C1 and C2. So those aren't really working right. I don't think that that is the cause of this inner ear issue, but it's not helping, and it might be a result of issues in the inner ear, and something that can be addressed with manual means in just a few minutes, so we might as well do that. So based on my kind of initial scan, left side in particular, lower cervical, kind of a compressive feel, and on the right side, more upper cervical issues relating to a trigger point in this SCM and some joint restriction here through the right upper cervical spine, which leads me to think about postural issues, again, with the sternum depressed and the shoulders rolling forward, that upper crossed syndrome posture, which, correcting that is outside the scope of a chiropractic session, but we can get some things moving in the right direction there. So we're going to start with this sternocleidomastoid trigger point right there. So it's right between my finger and my thumb, and you can see this muscle kind of popping out as I'm grabbing it and pulling it. So this pressure is not very deep, but it's very direct. I'm right on the knot. You okay here, Brie?
Mm-hmm.
Okay, good. So what we want to do is remember that trigger points form as a result of lack of local circulation. So our intention here is to improve circulation to this area. So I'm just gently working the muscle. I've got the muscle right between. As I'm coming down along the shaft of the muscle, I'm encountering kind of the central knot right there. It feels like someone chewed up a piece of gum and then put it in the muscle right there. Is that sensitive?
Mm-hmm.
Okay, so we don't want to overwork it. We just want to work it a bit. So I'm a little closer in now on this SCM. And so here I am on the muscle, and I'm going to gently let that muscle slide out from under my fingers and get on the fascia here. So this is between my fingers here. This pinch is not muscle, it's fascia, between muscle and skin. And I don't know, for whatever reason, this particular trigger point in the SCM really tends to create fascial restriction. And it's really key to work that layer of the tissue as well. A couple of deep breaths here, Brie. Yeah, so I'm grabbing it, I'm tractioning it away from her body, getting space between the fascia and the muscle so that blood and lymph can flow. And again, as always, it's important not to overwork these tissues. So give them a little bit of a break. Come here and just kind of work this masseter, zygomatic, temporalis complex right here. So I'm definitely feeling tension on the temporalis muscle here. And we work this muscle almost basically on anyone who has neck, head, or shoulder issues, because this is a jaw closer and a jaw retruder, meaning it pulls the jaw back. And so anyone who's clenching their teeth a lot is overusing this muscle. So the inferior fibers are here, kind of running horizontally, and then the superior fibers are going to be running more vertical and oblique up here along the temporoparietal suture, also known as the squamosal suture, right here. So just like any other muscle, it gets tight, it gets overworked, it gets unhappy, and it likes to have a little bit of stretch, a little bit of touch, a little bit of movement. Brie, would it be okay with you if I used your hair to stretch your scalp?
Sure.
Yeah. So I want to get, if you want to use hair pulling as a technique in body work, you got to get down close to the roots, get a big bunch of the hair, and you want to give it a slow traction like this. So it's not a yank, and you don't want to hold it by the ends, and you want to make sure you have kind of a nice handful before you pull. So I'm going to release, and you can see the amount of glide in the skin there is actually pretty significant. It's about an inch, maybe a little more. But this is a really good way to stretch the skin and fascia around the temporal bone, just like that. Good. With my left hand, I'm cupping her occiput and giving a simultaneous traction toward me. I'm going to do that one more time, okay?
Mm-hmm.
Good. So pull. Good. Almost like lengthening her whole body from the scalp. Okay. So continuing on this right upper, coming behind the ear, there's her mastoid process. There's the occipital ridge right there. And let's take a look at the movement between the occiput and C1. So that's better than it was a minute ago. So I think what we are doing is good. It's moving us in the right direction. And the primary area of restriction now is posterior to the sternocleidomastoid. So here's the sternocleidomastoid here, pulling it anterior, and then behind it, the muscle in this area is going to be the levator scapula, posterior scalene, and the tension that I'm feeling is really spanning almost now the whole cervical spine. So I don't think that that is intersegmental restriction or dysfunction. I think that's going to be her levator scapulus. So with my middle finger here, I have found the top of her scapula, and we're going to work that levator from the bottom to the top. So what the levator is going to do when it's tight is pull that scapula into an upward rotation. And so my job here, as we open up and invite this muscle to chill out, is scapular depression and inferior rotation. So Brie, I want you to take some big chest breaths here while we do this, okay? Breathing in, breathing out. Good, let your head come toward me. I'm not going to do anything quick or sudden. Just keep breathing. And we're gonna help this muscle open up. Relax, beautiful, really nicely done. And what's starting to happen now as it relaxes is that the more discrete knots within the muscle become palpable. And there's one right there, right there. Good. So giving it a little more TLC. We're not forcing anything. We're inducing movement. We're inviting the body to open up. We're definitely creating a lot of awareness within the system, bringing information, proprioceptive information to the brain through touch. It's haptic feedback, like if your phone vibrates when you touch the keyboard. That's haptic feedback. Well, it works also within the body. We're touching these tight areas, bringing awareness to the brain so the brain can make some decisions about what to do. Gonna continue now.
Mm-hmm.
This next piece is a scapular release. So I'm gonna get this hand underneath. My three fingers are between the scapula and the thoracic spine. And if I could have your hand. Gonna get a hold of her wrist, keeping the hand pronated, which really allows for a lot of nice horizontal adduction. So pulling the scapula away from the spine while I work the rhomboid and the middle trapezius and those upper thoracic segments and ribs like this. So she is breathing and keeping her arm relaxed. Good. So we want scapula movement. As the elbow comes up toward me, the scapula is depressing. As the elbow comes away, the scapula is raising. And we're just working it, making sure everything is nice and mobile, which feeling some stuckness, as you often do, right where the scapula meets like the third or second rib. And just a fingertip. So my index finger is kind of crooked like that. And just using that as a little bit of a fulcrum to create a little space between the scapula and the rib cage. So that shoulder blade rests on the rib cage, the ribs run right in front of it, and the subscapularis muscle is there. You get a lot of restriction and adhesion in that area. And if the scapula can't move very well, you really don't have a lot of opportunity for healthy neck motion or position. So just kind of bringing a little bit of that treatment now into her upper trap, right there. Again, just like we did with her SCM, creating space between the fascia and the muscle. So here, I'm grabbing the muscle. Here, I'm just on the fascia. And I'm lifting that fascia, stretching it, getting some space between it and the muscle. What flows through fascia? Nerves, blood vessels, lymphatic vessels. When that fascia is constricted and fibroblasts have contractile quality, it'll cut off nerve flow, it'll cut off blood and lymph flow, creates a little pocket of dysfunction and local endotoxicity, not in a way that is life-threatening, but in a way that causes the tissues locally to decondition. And so we talk a lot about that spectrum and timeline from deconditioning to degeneration. Once deconditioning has been present for long enough, the tissues will start to de-differentiate. So where there used to be muscle, it'll become fibrous tissue, much less functional, much less differentiated tissue. Body work is a really good way to intervene in that process. And if it's caught early enough, it's totally reversible. Tissues can be reconditioned, and this fibrosis and degeneration can definitely be avoided. And that's why I do what I do. So we're going to switch now and look at your left side. Okay?
Okay.
Okay, you doing good? Yeah, you're doing good. Okay, we're moving over to her left side. And remember, before we found that what I call a compressive feel in those lower cervical vertebrae. And we have to come back in and approach this with an open mind, because we did shift a lot of things on the right side. So things on the left side are probably going to feel different as well. And they do. It's much less constricted over here. In fact, it feels like those vertebrae really did release. And what we're left with now is tension. I'm going to get it between my fingers. That's the lower SCM. So let's just take a minute and talk about working in the scalene triangle, because it's really necessary. A lot of people need this work, and a lot of body workers are afraid to get in there. So let's get a closer look. You okay with this, Brie?
Mm-hmm.
Okay. So in fact, if you could take your hand and hold that for me. Yeah, just kind of hold it down. Okay, landmarks here. There's her clavicle. That's the lower part of the sternocleidomastoid tendon. So there's the sternocleidomastoid here. And here behind my finger is her upper trapezius. So the scalene triangle is right here. And what we have in here are some really important and really delicate structures, okay? So not exactly in the scalene triangle, but very important to us is the trachea, the windpipe. Never, ever, ever do you want to press on it. The person will feel very uncomfortable and probably start coughing right away. And you're going to send their whole nervous system into alarm if you do. Right about here, we have what goes by various terms, but I'll call the neurovascular bundle. So that's going to be the subclavian artery and the brachial plexus. It comes out between the anterior scalene and the middle scalene, and it's right here. And it's pretty distinctive because it has a pulse. Because that subclavian artery, being very close to the heart, has a very distinctive pulse, and you can see it. You might even be able to see it on this video. We'll see how that comes out. And we don't want to manipulate the neurovascular sleeve. We don't want to get on the trachea. What we want to be able to do is get on the anterior scalene and the middle and posterior scalene. so we can assess and evaluate the tone, texture, and mobility of those muscles, okay? So anytime there's a delicate structure in an area where you want to work, the first thing to do is locate it. So then you know where it is, and then you can stay off of it. So Brie, I want you to just let me turn your head, okay? So as I turn her head to the right, there's going to be lengthening of her anterior, middle, and posterior scalene, as well as levator scapula. You think about the morphology of these muscles. Anterior scalene connects the top ribs to the front of the cervical vertebrae. Middle and posterior scalene connect to the side of the vertebrae. And then behind that is the levator scapula, which attaches the vertebrae to the top of the scapula. It's almost like the levator scapula is a fourth scalene, but instead of attaching from the cervical spine to the ribs, it attaches to the scapula. And has very similar function, has very similar feel in terms of its palpatory presentation, and it will tend to dysfunction together. And it does feel to me, as I'm moving her head to the right, that these posterior middle scalene and levator scapula are really stuck in their lower aspect. So this is going to be our focus of work right here for the next few minutes. Brie, you can let go of your shirt collar. Thank you. I'm just going to open that up a little bit so we get a little more like that. Okay. So the upper trap is this, and that's really not what we're working on right now. Just deep to or anterior to the upper trap is that levator scapula right there. So I'm turning her head and tilting it to the right, meaning the left one gets a stretch. But because I've tethered the lower part to the scapula, it's just going to be stretching that tissue that is really stuck. And I'm not doing this forcefully. I'm doing it gently but directly, and I'm doing it in kind of a rhythmic way. Some of this is going to be, again, some deconditioning and possibly fibrosis or degeneration of some tissue. But some of it is just nervous system's decision about how much tone these muscles need. And that can be changed, just like with a gentle suggestion that maybe it's okay to let go. So now you can see I've got a big pinch, and right there, it's going to snap right under my thumb. That is a levator scapula trigger point. It's about an inch or two superior to the superior angle of her scapula. And again, just like before, I don't want to overwork it. I just want to work it a little bit. And then we're going to shift onto that fascial plane, and right there. I wonder if you can see that on the video. I've got the muscle between my finger and thumb now, and that muscle is going to slide out right there. And now it's just fascia. It has a whole different feel to my fingers, and I think it has a really different feel to the patient's body too, when you're pinching and stretching the fascia. If this were a different part of the body, I might be using a cup. But it's very hard to get cups to work in the scalene triangle. It's because of the contour of this part of the body. So using my hands, and always committed to taking good care of my hands, which means giving myself breaks and self-care time during the day, but also in a treatment, like within the 20 or 30-minute treatment, making sure that I give my hands little breaks and do some things that are easier in between the things that are harder. So here I am now. I'm on transverse process of C2. This is the very top of the levator scapula, the other end of this muscle. Got the SCM here is in front of my finger. The upper trap here is behind. And so what exists here? It's got to be the levator scapula, or possibly a little bit of the posterior scalene. And just getting some movement. You can really feel things opening up. This is not forceful. This is gentle. This is safe. So even with a patient who has a sensitive nervous system, a sensitive person, small frame, even a person with osteopenia or osteoporosis, this would be safe because the pressure is not that much on the bone. The movement is all within physiological range. There's no excessive movement being put into the system here. So let's open up this left scapula, and that'll probably finish up our session today. Can I have your left hand? Mm-hmm. So just like we did on the right side, yeah, good job relaxing your arm there, Brie. And I've got my fingers between the thoracic spine and the scapula, pulling the scapula away from the midline by pulling the shoulder into horizontal adduction. And just working those tissues, exposing some of those tissues between. I'm switching my grip here a little bit because I want to get a little more of an outward push. So my right hand is actually pushing this way as I'm pulling her scapula away. And there, just let go. Good. Again, a lot of times people's bodies just need a suggestion. Sometimes it needs force. Sometimes it's just a matter of relax your elbow. Getting a little bit of space in there and reminding the body that, in fact, it is possible to let go. Great. Good. So here, let's finish actually with some work on this temporalis muscle here. Yeah, okay. So even though Brie has been dealing with a lot of health challenges, I would not classify things that I'm feeling here as being unusual or remarkable. It's just kind of run-of-the-mill modern human stuff. So I don't know if that gives you heart, but there it is anyway. Thank you, Brie. I appreciate you coming in today and volunteering for this. You good?
Yes.
Thank you so much.
Yes.